Hello, my friends. I'm Dr. Rachel Storms, and today I want to give you something most people never get in a short doctor's appointment: a guided tour of your own kitchen. Identifying specific items that, if you take Amlodipine or Losartan, may be quietly working against your medication every single day. The most dangerous one, the one that sits in the kitchens of the majority of older adults I see, is something I want you to literally walk to your kitchen and look at after watching this video. It is so ordinary that it would never occur to most patients to question it. And yet for patients on these two specific medications, it is one of the most clinically significant interactions I encounter in my practice. Stay with me through the full video because the framework I am giving you today is not just about one item. It is about reading your kitchen the way I would read a medication chart, identifying the inputs that interact with what your physician prescribed. By the end of this video, you will be able to walk through your own kitchen and spot the items that need to be reconsidered. I will reveal the most important one in the first 10 minutes, not at the end, because withholding it would mean some viewers stop watching and miss the warning. But I will keep building from there, because the full picture matters. Let me start with the two medications and what they are trying to do, because understanding the mechanism makes the kitchen interactions intuitive rather than memorized. Amlodipine is a calcium channel blocker. The way I explain this to patients is that calcium is the key that smooth muscle cells in your artery walls need in order to contract. When calcium flows into the muscle cells through specialized channels, the muscle tightens. The artery narrows and blood pressure rises. Amlodipine blocks those channels, partially. Less calcium enters the cells, the muscle stays relaxed, the artery stays open, and blood pressure falls. Think of it as a key that fits into the lock but does not turn it, occupying the keyhole so the real key cannot get in. Losartan works on a completely different system. There is a hormone called angiotensin II that, when it binds to its receptor, causes blood vessels to constrict and tells the kidneys to retain sodium and water. Losartan sits in that receptor like a door wedge, blocking angiotensin II from doing its job. Vessels relax, sodium and water are excreted. Blood pressure falls. Different mechanism, similar end result. Both medications have an important property in common that creates the vulnerability we are discussing today. They both have their effects modified, sometimes dramatically, by specific compounds found in everyday foods and household items. The medications were studied in clinical trials under controlled conditions. Your kitchen does not match those controlled conditions, and the difference can change how well or how safely your medications work. I want to give you the most important item now, the one I asked you to walk to your kitchen and check. The item is a salt substitute. The container often looks similar to a regular salt shaker, with branding that emphasizes low sodium, heart healthy, or salt-free. Common brand names include Morton Salt Substitute, No Salt, and various store brand versions. The active ingredient in these products is potassium chloride, not sodium chloride. They are not diluted salt. They are potassium replacements for salt. For most people, switching from sodium to potassium for seasoning is a reasonable substitution. The general American diet is too high in sodium, and increasing potassium relative to sodium is consistent with cardiovascular guidelines. But for patients on Losartan specifically, and to a lesser extent for patients on any medication in the broader class of ACE inhibitors and ARBs, this substitution can become dangerous in a way that builds gradually over weeks to months. Losartan, by its mechanism, reduces the kidney's excretion of potassium. The kidneys retain more potassium than they would without the medication. Layer onto this the potassium load from a salt substitute, used liberally because it tastes salty and feels healthy, and the cumulative potassium intake can exceed what the kidneys can clear. Serum potassium creeps upward. Mild hyperkalemia develops first, causing symptoms that are vague and easy to attribute to other causes: muscle weakness, fatigue, palpitations, an occasional irregular heartbeat. Severe hyperkalemia, which can develop suddenly if dehydration or another precipitant is added, causes cardiac arrhythmias that can be life-threatening. I have seen this pattern repeatedly in clinical practice, and what makes it particularly insidious is that the patient is doing exactly what they have been told to do. They have reduced their sodium. They have purchased the salt substitute. They have no idea they are stacking potassium on top of an already elevated baseline. Their physician, in a 15-minute appointment, does not ask about salt substitutes specifically. The kitchen item that is hurting them is invisible to the clinical conversation. The action I want you to take, if you are on Losartan and you have a salt substitute in your kitchen, is this: stop using it. Replace it with the practice of reducing processed foods, which is where the vast majority of dietary sodium actually comes from, rather than trying to compensate for sodium with potassium. If you are not sure whether your salt substitute contains potassium, look at the ingredient list. If you see potassium chloride, that is your warning. And at your next appointment, mention to your physician that you have been using a salt substitute and ask whether your potassium level needs to be checked. Now let me build on this with the next item, which is grapefruit and grapefruit juice. This interaction applies specifically to amlodipine and is one of the most clinically significant food-drug interactions in all of medicine. The compounds in grapefruit called furanocoumarins irreversibly inhibit a liver enzyme called CYP3A4, which is responsible for the metabolism of amlodipine. When this enzyme is inhibited, amlodipine accumulates to higher levels in the blood than the prescribed dose was intended to produce. The effective concentration of the medication can increase by 50 to 80%, which translates to exaggerated blood pressure lowering, peripheral vasodilation, dizziness on standing, and an increased risk of falls. I have heard patients tell me that they only drink grapefruit juice occasionally, with the assumption that occasional exposure is safe. The mechanism does not support that assumption. The enzyme inhibition from a single glass of grapefruit juice lasts 24 to 48 hours, and in some patients may extend longer. There is no safe occasional consumption of grapefruit while taking amlodipine. If you take amlodipine and there is grapefruit juice, or marmalade made from Seville oranges, which contains the same compounds, in your kitchen, those items need to be removed entirely. This is not a portion control conversation. It is an elimination conversation. Now let me move to the next layer of kitchen items, which is less universally recognized, but which I want to bring to your attention because the interactions are real, even if they are subtler. The first item in this layer is your cookware, specifically non-stick pans that are scratched, damaged, or older than 5 years. The concern is not the original Teflon coating itself, which, when intact, is largely inert. The concern is the perfluorinated compounds, including PFOA, and related chemicals that can be released when non-stick coatings break down through scratching, high heat, or aging. These compounds have been associated in epidemiological studies with elevated blood pressure, increased cholesterol, and altered kidney function. They are not the dominant driver of hypertension for most patients, but they represent an unnecessary additional input. The simple action is replacing damaged non-stick cookware with stainless steel, cast iron, or ceramic alternatives. The second item in this layer is your cooking oil. I have discussed this in multiple previous videos, and I want to reinforce it specifically in this kitchen audit context. Refined vegetable oils, including canola, corn, soybean, sunflower, and safflower oils, are extremely high in omega-6 fatty acids. The ratio of omega-6 to omega-3 in the typical modern diet is around 15 to 1 or higher, compared to the 4 to 1 ratio of traditional diets. This imbalance drives systemic inflammation that contributes to arterial stiffness and impaired endothelial function, which is the layer of cells that lines blood vessels. Your blood pressure medication is trying to relax those vessels. The inflammatory environment from omega-6 excess is making them less responsive. The substitution is to replace these oils with extra virgin olive oil for cold use and low heat cooking, and avocado oil for higher heat. Both have substantially better omega-6 to omega-3 ratios and anti-inflammatory profiles. The third item in this layer is the foods that are usually present in older adults' kitchens, specifically because they have been told these foods are healthy, but that interact with blood pressure medications in unexpected ways. Cured and processed meats, including deli turkey marketed as a lean alternative, contain sodium loads that work directly against Losartan's blood pressure lowering effect. I have covered this in previous videos. Packaged whole grain crackers and breakfast cereals that are marketed as heart healthy often contain 700 to 900 milligrams of sodium per serving without tasting salty enough to alert the consumer. Black licorice, particularly traditional black licorice products that contain real licorice extract, contains glycyrrhizin that directly raises blood pressure and negates the effect of all blood pressure medications. Let me also address the herbal supplements that often live in the kitchen rather than in a separate medicine cabinet. St. John's wort, which is sometimes purchased for mood support, strongly induces the liver enzymes that metabolize amlodipine, reducing its effective concentration. Licorice root, which appears in some digestive teas and supplements, has the same blood pressure-raising effect. Hawthorn extract, sometimes recommended for general heart health, can have additive effects with blood pressure medications that produce excessive blood pressure lowering in some patients. These need to be part of the conversation with your physician. Now let me address the breakfast question, because the morning meal is where many of these interactions converge. The classic problematic breakfast for a patient on amlodipine or Losartan looks like this: a glass of grapefruit juice or orange juice with calcium added, a bowl of oatmeal with milk, a banana sliced on top, and a cup of coffee. Each of these items individually is a reasonable food. Together, they create a perfect storm. The grapefruit juice inhibits amlodipine metabolism. The calcium-fortified juice or milk competes with amlodipine at calcium channels. The banana adds substantial potassium to a system already retaining potassium from Losartan. The oatmeal's soluble fiber can bind certain medications and slow absorption. The coffee, taken close to the medication time, has its own vasoconstrictive effects. The blood pressure reading at the doctor's office later may not reflect the chaos. The corrected breakfast protocol that I recommend integrates everything we have discussed. Take your medication with plain water at room temperature 30 minutes before any other food or beverage. After that 30-minute window, have a breakfast that includes protein and healthy fat without excessive potassium loading, eggs with avocado on whole grain toast, Greek yogurt with a small amount of berries, smoked salmon with cucumber on a whole grain bagel. These breakfasts provide stable blood sugar, anti-inflammatory inputs, and no significant medication interactions. The shift from the typical American breakfast to this pattern is one of the highest impact dietary changes you can make. Let me now give you the practical kitchen audit you can do this week. Set aside 30 minutes to go through your kitchen systematically. Open the spice cabinet and locate any salt substitute. If you find one, remove it. Open the refrigerator and identify any grapefruit, grapefruit juice, or Seville orange marmalade. Remove these. Look at your cooking oil collection. If they are refined vegetable oils, plan to replace them. Look at your cookware and replace damaged pans. Look at your pantry and identify your most consumed packaged foods. Read the sodium content. If it's more than 300 milligrams per serving, find alternatives. Finally, gather any herbal supplements or specialty teas and bring the full list to your next physician appointment. Let me give you the specific language for that physician conversation. The questions that have been most useful for my patients are these. First, I have been using a salt substitute. Could you check my potassium level at my next blood draw? Second, I take amlodipine, and I want to confirm no other foods or supplements interact with it. Could we review my list? Third, given my situation, is my current medication regimen still the right one? These questions open conversations that appointments often miss. Before I close, I want to name something that I think matters. The pattern that emerges across this entire video is that older adults are doing what they have been told to do, what marketing suggests is healthy. They have reduced sodium and added a substitute. They are eating oatmeal because it lowers cholesterol. They drink juice for vitamins. None of these choices is individually unreasonable. The problem is the cumulative interaction, the way these reasonable choices combine in ways that nobody connected for them. My role across these videos is to do that connecting, because the system as currently structured does not have time to do it, and the patient is left to navigate the complexity alone. Share this video with someone you know who takes a blood pressure pill. The salt substitute conversation alone could prevent a hospitalization. Send it to your sister, your neighbor, the friend you have coffee with on Saturdays. Walking through their kitchen with them is an act of care that has direct physical consequences. And if you want to understand the next layer, watch my video on what to stop doing every morning when taking these medications. It takes what we discussed today and shows you how to integrate it into a routine. Watch that video next.